we're talking about treatment in a metastatic setting. In colorectal cancer, we've seen this concept of maintenance therapy. It's at one point we're talking about stopping therapy and giving patients a break. And so a lot of people are using this across the lines in terms of GI cancers. Manish, I mean, when you see a patient with first-line metastatic disease, do you talk about maintenance? Do you think about maintenance or stopping treatment, or what would you do?
Yeah, great question, and I think it comes up often. So if you're using FOLFOX, I think it's very, very hard to give oxaliplatin for more than 4 or 5 months without having debilitating neuropathy or fatigue or other symptoms. So I think there's sort of a natural way then to continue 5-FU, which I call less intensive therapy, which is also known as maintenance. You know, I think I personally take the Optimox data in colorectal cancer to heart, and which basically for me showed that some treatment actually is helpful, and taking a complete break in treatment may not be so good between Optimox 2 and 3. So I think that for me, I do use maintenance 5-FU in the HER2 positive patients. I think it's great to use maintenance Herceptin, very low toxicity. We'll talk about this in the in the future, but ramucirumab, very low toxicity, might be another option for that as well.
How about you, Yelena?
I would agree that this is a tumor with aggressive disease biology, and you need to suppress growth of micrometastatic or macrometastatic disease, and extrapolating from other solid tumors such as colon or lung adenocarcinoma, continuing maintenance therapy or less intense therapy is very important. And unfortunately, there's no level 1 evidence to support it, and it emotionally sometimes difficult for the patients to hear that. Occasionally, we do give them an extra week or a month off here and there, but it is important to continue it.
Yeah, so no complete stops. Ian, same thing?
We have a different view. We have actually a complete different view, because our standard is actually to stop after 6 to 8 cycles. So after 4 to 6 months, we actually stop treatment completely. That is the standard of care that we have been adopting. We do recognize the need to generate level 1 evidence, and in fact we are running a randomized study called Platform at the moment in the UK, where the standard arm is to stop, and then we have maintenance capecitabine, and then maintenance PD-L1 antibody. So we do want to try to generate the level 1 evidence to support or not support the use of maintenance therapy. Because again, I think different countries, different patients have different expectations and cultures. Because for us to tell our patients that they're not going to get a break, the first thing they said is, I want to start you on chemotherapy, then they ask, when can I go on holidays? And that's quite different. Whereas we also have some Southern Europeans, and those patients actually perhaps behave more like the US patients. If you want to try to stop their treatment, they won't let you. Okay, so I think there are different cultures and different expectations, and I think in the end we do need to generate that evidence. But also I think at that point, as Manish said, is also a good timing to do clinical trials as well, because patient already had a good period of chemotherapy, the disease is controlled. Now you really want to see agents whether that really can extend the fat with hopefully low toxicity.
Now,
I was just going to say, I mean, I think it's fantastic that the trial that you mentioned. In contrast, in the United States, the paradigm had always been treat until progression, even when we were giving really toxic treatment, which was really tough. And so I think we've evolved to sort of say treat until progression, but less intensive therapy. So that's sort of how that paradigm was a little bit different. But I think getting data and proving it is really helpful.